Welcome to the Dr. Mark J. Pamer podcast, a doctor who uses his heart to treat your lungs. Here's your host, Dr. Mark J. Pamer.
Welcome back, everyone. Garfield Bowen here, co-host / producer of the show, back in the studio with Dr. Pamer. Dr. Pamer, how you doing today?
I'm great, Garfield. Thanks for having me.
Yeah, want to learn all about all that knowledge that you got there. I'm happy taking some time to share some wisdom with our audience here. I did a little research and I looked up pulmonologist. A pulmonologist is a medical doctor who specializes in the diagnosis and treatment of lung disease and respiratory system disorders such as asthma, chronic obstructive pulmonary disease, COPD, pneumonia, lung cancer, sleep apnea. They may also provide treatment for patients with breathing problems caused by other medical conditions such as heart disease and neuromuscular disorders. Did I get that correct?
That was a mouthful.
Okay. For this episode, we're going to talk a little bit about chronic obstructive pulmonary disease, COPD. What is COPD?
COPD, by its rightful name, is chronic obstructive pulmonary disease, COPD. In some parts of the world, it's called chronic obstructive lung disease, but that acronym ends up being cold. But we have COPD over here in the United States. And COPD is a condition which we most closely associate with smokers. But the underlying reason for the disorder is the inhalation of stuff that we shouldn't be inhaling. Generally, some inorganic dust or a metal dust, or certainly smoke. Cigarette smoke is the biggie. And it causes an inflammatory disease in the lungs, which ultimately causes the destruction of elastic fibers, and this beautiful fishnet stocking that's holding together 300 million air sacs starts to come apart. And as these holes develop in the lungs, then that's called emphysema. And if that doesn't happen, or sometimes it happens with it, all that smoke can cause a reaction by the inner lining of the lung, the mucosa, to become thickened and start to make mucus, seemingly for a living. And we call that condition chronic bronchitis, when you've been coughing up at least 3 months worth over the prior 2 years. And so currently our definition of COPD is either emphysema or chronic bronchitis when there's been some impairment of lung function resulting in the big O, obstruction, thus chronic obstructive pulmonary disease. And that obstruction is difficulty getting the airflow out. It may be noticeable to the person, it may not be noticeable to the person, but if you've got obstructive lung disease and emphysema or chronic bronchitis, then you've got what's called COPD.
Wow. So is there a fix, or do you slow it down? What do they come to? What's your solution for that?
Great question. So COPD is extremely common. There are millions and millions of Americans who have COPD. Part of the good news here is that it's only the minority of smokers that actually get it. Ultimately, it's due to some imbalance between the inflammation caused by the smoking or the dust or the smoke inhalation and an inability of the person to combat that inflammation. And if you can't go toe-to-toe with the inflammation, you'll probably end up with COPD. Even at a pack a day, maybe 15 to 25% of smokers get COPD. At 2 packs a day, maybe it's somewhere between 25 to 30 or 40%. Whatever the percentage is, if you develop this condition, then shortness of breath is generally one of the things that a person may start to experience as their lung function falls. And they may have a chronic cough. Sometimes they get wheezing, musical sounds in the chest tightness, might be worse at night. It can walk hand in hand and be difficult to differentiate from asthma. Sometimes the two conditions occur together. But the mainstay of therapy are bronchodilators, medications which we inhale, which help the lung tubes to open up. And by doing that, it makes it easier to breathe. That's the mainstay. Separate from that, we've got other things that we can prescribe as well. And some of these bronchodilators are long-acting and they can last for up to 24 hours. Sometimes they're short-acting. They might only last 2, 3, 4, or 6 hours. There's different classes of bronchodilators. There's other things which we might give, like steroids, to reduce inflammation in the lungs themselves, to help that airflow move better, or to decrease inflammation, to decrease mucus production. There's antibiotics which we can give, which may control bacterial growth or reduce inflammation. There's some other medications, which such as theophylline, which may help to open up the lungs on its own and maybe reduce inflammation. And there's several other medications as well. And there's a few ones coming down the pike that'll be showing up here on the clinical horizon in the next year or two, all of which help to open up the lungs and decrease inflammation. That's on the medicinal side of it. There's things which I can do, or any pulmonologist can do, on the non-pharmaceutical side to help people breathe better. And one of them is so simple. It's just teaching people how to use their inhalers. 50% of people don't use albuterol inhalers correctly. And so half of the people, I've got an opportunity to say, show me how you use your inhaler. Let me correct that and show you how to use it. It's just an interesting statistic. But, even with perfect technique using an albuterol inhaler, only 10% of the medication gets into the lung. So if you're not using your inhaler correctly, what percent is getting in? It's obviously a lot less. So teaching people how to use their inhalers is really important, as well as making sure they're using them correctly. If it's a twice a day inhaler, are they doing it once a day? If it's 2 puffs twice a day, are they taking 1 puff once a day? Working on that compliance is very, very important. But there's other things like teaching them how to breathe, what's called pursed lip breathing, when they walk, which smell the roses, blow out the candle. It sounds simple, but it's a very important maneuver which allows someone to release the trapped gases in their chest to contribute to their shortness of breath and the overinflation of the lung. Pulmonary rehabilitation is also extremely important for patients who've got at least moderate COPD or worse. It's a Medicare covered entity. If you've got Medicare in a secondary, it's covered 100%. If you've got a Medicare Advantage plan, there will be a cost. And if it's a commercial insurance, there will be some cost, most likely. But pulmonary rehabilitation is really one of the secret weapons of pulmonologists, that we can help people to walk a lot further, be a lot less short of breath, get fewer exacerbations, and hopefully keep you around on this planet longer and with better quality of life. So there's more that we can add other than that, but it comes down to a combination of bronchodilators and some non-bronchodilator therapies, such as teaching people how to breathe, pulmonary rehabilitation, and making sure they're using their inhalers correctly.
I remember in school, they taught you how to breathe in through your nose and out through your mouth. So that's really, really interesting. So I guess we want our listeners to know that those with COPD, they need to reach out to Dr. Pamer, because there's help. Okay, good stuff. You have a wonderful rest of the day. We'll see you on the next episode.
Thanks for listening to the Dr. Mark J. Pamer podcast. To learn more about the doctor who uses his heart to treat your lungs, go to markpamerdo.com or call 772-785-5864. Once again, that's 772-785-5864.